I'd like to present a study entitled "Is Highly Mobile Bladder Evaluated by Dynamic Magnetic Resonance Imaging Associated with Voiding Dysfunction in Patients with Pelvic Organ Prolapse?" Pelvic organ prolapse causes voiding dysfunction, probably due to bladder outlet obstruction and/or detrusor underactivity, although the definitive mechanisms remain to be determined. Voiding dysfunction in pelvic organ prolapse is usually associated with high-grade cystocele. Recently, dynamic magnetic resonance imaging is thought to be useful for delineating the descent of each pelvic organ during abdominal straining without radiation exposure. In the present study, we investigated the associations between voiding dysfunction and pelvic organ mobility evaluated by dynamic MRI. Our hypothesis was that patients with voiding dysfunction had a more mobile bladder. We included 118 patients with a mean age of 60 years old who had pelvic organ prolapse of stage 2 or less at rest and stage 3 or more when straining during dynamic MRI. The presence or absence of voiding dysfunction was demonstrated by a voiding international prostate symptom score equal and more than 5, maximum flow rate less than 15 ml per second, and post-void residual urine volume more than 50 ml. Using the sagittal images of dynamic MRI, we measured representative points of the pelvic organ, that is, coordinate positions of the bladder neck, the most dependent position of the bladder, uterine cervix, and anorectal angle before and during straining. Pelvic organ mobility was evaluated by the distance between coordinate positions of the representative points before and during straining. In addition, we also measured imaginary uterosacral and cardinal ligaments, lengths of the urogenital hiatus, the hiatal descent, and the anterior vaginal wall length at rest and during straining, and calculated the changes between them. Finally, we measured the posterior urethral vesical angle and the angle of urethral inclination at rest and during straining, and calculated the changes between them. Voiding dysfunction was found in 36, 27, and 23% of the patients according to VIPSS-5, Qmax 15, and PVR 50, respectively. As shown in the slide, there was no statistically significant association between VIPSS, Qmax, and PVR. In terms of variables on dynamic MRI by IPSS-5, patients with voiding dysfunction had a more ventral position or movement of bladder neck, the most dependent position of the bladder, uterine cervix, and anorectal angle, longer uterosacral and cardinal ligaments, and a smaller angle of urethral inclination. In terms of variables on dynamic MRI by Qmax 15, patients with voiding dysfunction had a more ventral position of uterine cervix, less caudal position or movement of anorectal angle, longer cardinal ligament, larger change in the anterior vaginal wall length, and a smaller posterior urethral vesical angle. In terms of variables on dynamic MRI by PVR 50, patients with voiding dysfunction had a smaller posterior urethral vesical angle as well as the angle of urethral inclination. When assessing voiding dysfunction by the three criteria, the parameters derived from dynamic MRI that showed significant differences between patients with and without voiding dysfunction vary across these criteria. The symptoms seem to be caused by more ventral positions or movement of pelvic organs, as well as the elongation of the apical supportive structures. The Qmax reflecting detrusor contraction speed and bladder outlet condition was associated with the more bladder distension during straining against less sagging of the pelvic floor, which suggests that the decreased Qmax is implicated in reduced detrusor contraction speed and bladder outlet obstruction. PVR reflecting the degree in detrusor contraction duration as well as bladder outlet condition was associated with the narrower angle around the bladder outlet, which implied that the increased PVR in these patients might be caused by bladder outlet obstruction. In conclusion, factors other than bladder mobility could be also involved in voiding dysfunction in patients with pelvic organ prolapse. Thank you very much for your attention.